Firstly, I'd just like to acknowledge this is a presentation and an abstract that our stroke coordinator prepared, Jenny Pedler, who was unfortunately couldn't make it here at the last moment, so they asked me if I could present her paper, which I will try and do. So our journey in stroke in New South Wales really started around about that 2007, very similar to Victoria. And around that time, 2007, 2008, we collaborated with the John Hunter Hospital and the Hunter Medical Research Institute in Newcastle to improve stroke care out in the outer Hunter regional area of New South Wales. The goals were quite simple. It was to implement a transport pathway to improve access for specialist stroke units in regional areas and improve the access to early reperfusion of thrombolysis administration. And what we did, we got the project team together, or what they did, they got the project team together and looked at all the issues, and primarily it boiled down to the identification that ambulance was a huge key in the success of any sort of stroke initiative. So along with the colleagues in the John Hunter Hospital, we co-developed a Hunter 8 stroke score, which is modified NIHSS. We trained our paramedics in the fast stroke as well as the Hunter 8, and we did that through beer and pizza, mainly pizza. It's after hours. In the early pilot session, it was an unfunded project, and we wanted to get some paramedics on board to do a little bit of research, and the neurologists at the John Hunter Hospital provided their time in the after hours space to talk through the Hunter 8 with our paramedics. And it just grew from there. We implemented an early notification system, and that notification system was really the crews on scene would ring through the control centre. The control centre would ring the on-call neurologist. 9 times out of 10, by the time the crews got the patient to the John Hunter Hospital, the whole stroke team were there waiting, which was quite a good early notification activation system. We emphasised the need for rapid transport. We utilised aeromedical, the helicopter up in Newcastle, for those patients that were just a little bit too far to go by road. And over the 2-year period, the thrombolysis rates in the region improved from 5% to 20%, just with some of those simple actions put in place. So the success of that program started to be seen from a state perspective with the Ministry of Health, and they decided that what we need to do is try and replicate some of the success of the Hunter project and put it statewide. So in collaboration with the Ministry of Health and the Agency of Clinical Innovation, we got together. They established a stroke network in New South Wales Health, and some of their key goals were to identify and accredit the 24/7 acute thrombolytic centres in the state. Unfortunately, at that time we only had 4 in regional New South Wales. Most of them were in the metropolitan centres, and we also developed and agreed on a destination transport cascade. And back in those days, we would authorise our paramedics to drive up to 60 minutes with their patients if they were within that 3-hour, at that time, that 3-hour clinical window from when they were last seen well with their stroke, to go straight through to a thrombolytic centre. If they couldn't get there within that 60-minute drive time, they'd just go to a primary stroke centre. If not, the further out in the rural areas they were, they'd go to the nearest ED with medical coverage. But the whole time they were still activating the stroke system through the control system. There was a few operational issues that we had to look at once we started rolling this out statewide. We mapped what the impact would be on ambulance operations if we increased that drive time from 60 minutes to 90 minutes. So we mapped 60 minutes, 90 minutes and 120 minutes. At this point in time, it's just 90 minutes. And by extending that transport time from 60 minutes to 90 minutes, we got an extra 31 patients, which is quite a significant number in regional New South Wales, that could get to an acute thrombolytic centre within that 60-minute drive time. So shortly after that, we then in 2017, we extended the clinical window as the evidence became more available, extended the pre-hospital clinical window from 3 hours to the 4.5 hours so that we could get them there and activate the system, have it all done hopefully within the 6-hour period for thrombolysis. And we introduced a virtual stroke protocol into ambulance practice. One of the things we identified is that in our clinical practice guidelines, we just refer to them as protocols in New South Wales, is that we just have one stroke protocol. And this one stroke protocol number just covered all strokes, didn't matter what they were and whether it was a hospital transfer or whether it was a primary response to a patient's residence. So we introduced this virtual stroke protocol, and now we ask our paramedics that if they get a stroke fast positive patient, to use this virtual protocol and record C11P. And we're now starting to get some data now. So just in the last financial year, we transported 2,274 stroke fast positive patients. So we're building, we're trying to strengthen that system as we move forward. Also last year, we started to see a real lot of groundwork happening within the health environment in New South Wales with endoclot vascular retrieval stuff. And they established a new working group made up of neurologists and some of the CEs from the local area health services. So it was really an indication from the Ministry of Health that they really do support this idea about trying to get the patients to the right centre at the right time. So we're still working in that space at the moment. This map here just shows the 90-minute drive time and that we've got in New South Wales. So in 2012, we only had 4 centres, as I said. We had one in Dubbo, Lismore, Wollongong and Port Macquarie. Now we have an additional 4 sites, as well as 4 telestroke sites in New South Wales. So we can cover a far greater area of the state now. The numbers of patients with strokes who sit outside those 90 minutes, there aren't that many. I can't recall the exact number we've got, but the body of work we're working on now is collaborating with our aeromedical colleagues to see how we can utilise the aeromedical to help us get those other patients that sit outside that 90 minutes. But for example, for our June 2018, our KPI for the percentage of patients transported to a thrombolytic centre within the 4.5 hours of symptom onset. In Metro Sydney, our target's 90%. We're sitting at 99%, and that doesn't move too much. In regional, our target's 75%, and we're actually capturing 90% of patients now since we increased that time to 90 minutes. Some of the challenges we've hit along the road. We find there is a reluctance by some EDs, the physicians in some EDs, to actually thrombolyse patients. And we also find a varying mixture of responses from the hospitals once we notify them. The John Hunter Hospital notification system, where they would meet us by the time the ambulance got there, we tried to replicate that through the state. It's getting better, but we're not quite there yet. We've got a similar system at 2 of our other hospitals in New South Wales, but there's another 12 centres that we need to bring on board and get that notification system perfected, so they're there. So there's inconsistencies in the way stroke teams of the EDs activate their stroke teams. So by far from my observation is the best activation is by the paramedic directly to the neurologist. Some of the sites now who, and I don't know whether this is a result of our challenges around getting patients off stretchers in EDs, they tended to start sending them straight round to the CT scanner. So by default now, it just seems to be a common practice as if we do go to an ED, that may not be as proactive in stroke care as some of the other EDs. At least we can get them onto the CT table pretty quickly, which is something. So we currently do the drip and ship model for ECR now in New South Wales. The pathway is going to continually evolve as we move along this area of ECR. Each case, it's really not that efficient. We can do better. It takes 3 transports, one from the scene to the thrombolytic centre, then they need to wait until they work the patient up and get them moving to the clot retrieval centre, and then we have to decant them back to a stroke unit. So we, like Victoria and some of the work that you're doing down there, are starting to look at some tools and see how we can equip our paramedics to be able to identify those patient cohort who would benefit directly transport to the mothership. So with all the contemporary evidence that's coming out now, which is fantastic, the Dawn study, Diffuse 3, they're really game changers for us because now that we've got that clinical window of up to 24 hours. Now, while it's a game changer, it also poses a whole set of new challenges to us. Particularly with we're under a fair bit of pressure from some of our neurologists to drive 4 or 5 hours at a time with these patients, and so there's a reality there that we need to also mix into our system. But I understand that quite a lot of the jurisdictions around Australia are struggling with that at the moment. So, and the beauty about the Dawn, it really also included the wake-up strokes. So that we've now changed our clinical practice, which will be mandated from the 1st of October this year, that wake-up strokes will now be included in our criteria. And we'll keep working to see how we can expand that travel time. So the focus now is for us and with the Agency for Clinical Innovation, with their New South Wales Stroke Network, is develop a statewide system and have it come down from the top, from the ministry. We'll try and get expanded timeframes whilst minimising the operational impact on ambulances and other EDs as well. So it takes much more than, it will require a much more sophisticated notification activation system for us to pull that one off. So this next slide is really just a couple of examples of the drip and ship versus direct to mothership. And the first patient there is a rural patient. They waited 8 hours, 44 minutes to go to a clot retrieval. If we'd gone straight to the mothership, it'd be 60 minutes, so we would have saved 464 minutes there. And you can see from those next 2 patients there who are in the outer areas of the metropolitan area of Sydney, there's still a significant amount of time there that if we can perfect this direct to mothership for these patients who are identified for clot retrieval, we'll certainly have much better outcomes. So how do we put the evidence into practice? Like you down in Victoria with your Act Fast, we did some work with the John Hunter Hospital around the Hunter 8. So we're now talking, well, how can we use the Hunter 8 score, the assessment tool, to implement direct to mothership for us? We've all heard it. We do it well for STEMI, we do it well for trauma, getting these patients to the right centres. So we're going to embark on a body of work. We've only just started in the last 2 months. So from the 1st of October this year with paramedics, they will be using the Hunter 8 right throughout the state. So we're undertaking a process of socialising the Hunter 8 throughout the EDs and the stroke network. And the Hunter 8, it was retrospectively validated back in the early 2010. However, it was only published in 2017. But at the time, they found the cutoff was 7, and that had the highest sensitivity and specificity to detect large vessel occlusion. And the paramedics and neurologists conducting the score has substantial agreement with that. So paramedics performed the score, was on par with the performance of the score by the ED physicians as well. We're also introducing the modified ranking scale from the 1st of October this year. Paramedics are well placed to ascertain the patient's normal functions, see what their normal function was prior to their stroke, and by using the MRS, they're able to convey this information clearly to the stroke teams. So the patient's pre-morbid function is a key criteria for ECR. The initial validation of Hdraw that was also one of the recommendations in that 2017 paper that was published, was to do a retrospective study, and we're going to be doing that with the Agency for Clinical Innovation and the Stroke Network. We've also introduced a stroke process sheet, some prompt sheets for our paramedics. This was developed to guide paramedics in the acquisition of pertinent information for the stroke teams, streamlining the patient journey and minimising delays in history taking at hospital. It also assists in performing and documenting the modified ranking scale and the Hdraw score, and the sheet's now in all vehicles. We're just in the socialisation phase now, but as I said, from the 1st of October, it becomes mandatory for our paramedics. The Hdraw, that's just it's based on the National Institute of Health Stroke Scale. Our paramedics were involved in developing it. They selected the elements in collaboration with the neurologists at John Hunter Hospital, which they felt were most practical to apply in the field. So the other advantages of the Hdraw is that it's simple, yet it conveys a greater level of detail regarding specific neurological deficits that the patient has, over and above that of the FAST. So we've got some challenges as we move forward. We're a big state. Do we keep doing the drip and ship or direct to mothership? We need to consider the workloads of EDs. Some of the ED physicians are saying, hang on, we're going to end up with all these additional patients. It's not quite true. They'll just end up with that patient cohort a little bit earlier. You know, they seem to come on board when you put it like that. We need to develop a robust stroke activation process. We need to consider the distance from their primary stroke centres to the comprehensive stroke centres. Most of these patients still need lysis, and if they're eligible, so we don't want to delay any of that treatment. And we also need to consider our staff as far as possible when we're developing our tools and our drive time. We need to consider paramedic fatigue and all the other things as well, particularly out in the rural areas. So we also have all the technology. I know down in Victoria you're doing some work with Postara. There's talk of that in New South Wales around the network, the stroke network. We're having discussions about where telemedicine may come into it with our paramedics. And as our ICT capability advances, I really think that telemedicine, the use of iPads in the back of the ambulance is really going to be a bit of a game changer as well for this, particularly out in the rural areas. So, you know, of course, the other thing is we've had discussions about a mobile stroke unit in Sydney as well. We've been working with the Ministry of Health with that. There's no comprehensive answer of whether that's going to go ahead or not. We're still going through all the issues around where would it be located, where would it get the biggest bang for the buck, and all those sort of operational type issues. So we're going through all those discussions at the moment. So on behalf of Jenny, thank you.